Cardiac tamponade is the accumulation of pericardial fluid sufficient to obstruct ventricular inflow. It is a life-threatening emergency and can be rapidly fatal if untreated. Common causes include idiopathic and neoplastic pericarditis. Tuberculosis remains a major cause in developing regions. Bleeding into the pericardium may occur due to aortic dissection or trauma. Cardiac surgery and anticoagulant therapy are additional important causes. Pericardial fluid accumulation restricts ventricular filling. This leads to reduced cardiac output and decreased arterial pressure. Rapid accumulation as little as 200 milliliters can cause tamponade. Slow accumulation may reach more than 2,000 milliliters due to pericardial stretch. Beck triad defines the classic clinical presentation. Hypotension occurs due to reduced cardiac output. Heart sounds are soft or absent due to fluid insulation. Jugular venous distension is present with prominent X descent and absent Y descent. Pulsus paradoxus is defined as a fall in systolic blood pressure greater than 10 millimeters of mercury during inspiration. Electrical alternans may be seen with varying amplitude of P, Q, RS, and T waves. Chest X-ray may show sudden enlargement of the cardiac silhouette. Echocardiography is the gold standard for diagnosis. Findings include right atrial and right ventricular collapse during diastole. A large pericardial effusion and respiratory variation in Doppler flow are characteristic. Computed tomography and magnetic resonance imaging help in complex or loculated effusions. Electrocardiogram may show low-voltage complexes. Pericardial fluid analysis includes cytology, culture, and tuberculosis polymerase chain reaction. Bloody pericardial fluid suggests malignancy, renal failure, or post-cardiac injury. In developing regions, tuberculosis is a common cause of hemorrhagic effusion. Pericardial biopsy may be required for definitive diagnosis of tuberculosis. Differential diagnosis includes constrictive pericarditis and restrictive cardiomyopathy. Right ventricular myocardial infarction must also be considered. Effusive constrictive pericarditis is another important differential. Patients with large effusions must be closely monitored for progression. Pericardiocentesis is the definitive emergency treatment. It should be performed urgently when tamponade develops. The subxiphoid approach is the most commonly used technique. Apical and peristernal approaches are alternative options. Echocardiographic guidance is recommended to improve safety. Intravenous saline may be given while preparing for drainage. Pericardial pressure should be measured if possible. Complete drainage of fluid is recommended to relieve tamponade. A multi-hold catheter may be left in place for continued drainage. Surgical drainage is indicated in recurrent or loculated effusions. Subxiphoid thoracotomy or pericardial window procedures may be performed. Clinical takeaway is that cardiac tamponade is a rapidly progressive condition requiring immediate recognition and urgent drainage.